Good morning. My name is Stephanie Leung, and I am the project specialist for the Conversations of a Lifetime program at Hospice of Cincinnati. And I'm really honored and excited to be here today, and thank you all for coming. Just to give you a little bit of background about myself. So I never envisioned myself working in this area. My background is exercise science. You don't go into exercise science thinking you're going to be working in end of life. And I worked for a local health department for several years, working on healthy living initiatives in underserved communities. But what kind of prompted me to make the switch was a personal experience. So I saw my father being the primary caregiver of my grandmother in the last year and a half of her life, living with CHF, COPD, bouncing back from, she was 89 years old, living independently in a 3-story condo, and had a fall, which landed her in the hospital, and then rehab, and then assisted living, and then that bounce, over and over again. And my dad, who's very well educated, he's an engineer, didn't know how to navigate the healthcare system, and just saw that struggle. And it was soon after her death that I saw the opportunity to come to Conversations of a Lifetime, and I said, you know what, I can't explain it, but something is pulling me to be here. I'm just meant to be here. So that's kind of a little bit of a background on me and how I got here. I also want to acknowledge Barbara Rose, who is our senior program administrator and designed and really implemented this program long before I came on board. Some of you may have seen her. She was at CTEC in Denver a couple weeks ago, but just really want to thank her for her leadership as well. So for the next 40 minutes, I'm going to talk and really speak about the Conversations of a Lifetime program and the how and why we chose to pair Respecting Choices with the VitalTalk curriculum to make this a system-wide effort, and then also talk about some of the electronic medical record enhancements that we did to make them this system-wide and more sustainable. So to give you some background, so I work for Hospice of Cincinnati. We are part of the TriHealth system located in Cincinnati, Ohio. We are one of 5 health systems in that area, one of the largest, and Hospice of Cincinnati receives referrals from all health systems. We employ over 12,000 people in the greater Cincinnati region, and we're an integrated non-for-profit health system. So Conversations of a Lifetime, it began as a grant-funded program to really move the advanced care planning process more upstream and really focused on the primary care practices within the TriHealth system. And we had really 4 main components to this program. So the advanced care planning facilitator training, the physician coaching, the EPIC or the EMR enhancements to the TriHealth system, and technical support. And I'm going to walk you through each of those today. So the advanced care planning facilitator training. So we always like to take a picture at the end of our training, and we highlight it on our Facebook page. It's just kind of a nice way to highlight everybody there. And so we use the Respecting Choices Now Advanced Steps program. So Cincinnati first engaged with Respecting Choices back in 2011. It wasn't Hospice of Cincinnati that brought them, but when the Conversations of a Lifetime program was being designed, it really made sense to just build on the work that was already being done. So it became fully integrated into the Conversations of a Lifetime program in 2013. We currently have 1 organizational faculty, and we have 27 trained instructors. And right now, for about the past 18 months, I've been serving as the lead instructor. And I wanted to highlight a little bit about how we structure our classes. So many of our instructors are volunteers, not working for Hospice of Cincinnati. They might work in long-term care, primary care, critical care, and really bring a diverse background. And so for the small group role play exercises, we put a lot of thought into who are our volunteer instructors and who's going to be at the table with them. And we really like to kind of split up people who work together, because we found sometimes don't take the exercises as seriously. They get into, oh, you know, how are we going to make this work in our organization, and say this is really a time to forget all about that and just focus on the content and the script. And then, so recently, but in the past 6 months, because oftentimes our volunteer instructors don't really get a chance to network with each other, I've started a conference call a day or two before our trainings, just to say, hey, you know, introduce yourselves, how long have you been doing this, who's coming to the training, who's at your table, and just kind of strategize a little bit ahead of time. It's about 30 minutes, and we've gotten a lot of great feedback from that. So, like I said, we've been teaching the Last Steps training pretty much on a monthly basis since 2013. So we have trained over 800 facilitators in the greater Cincinnati region. And this is a breakdown of who those facilitators are. A majority are nurses, then social workers, and then the other category, we have chaplains, other Hospice of Cincinnati staff who have come through and said they wanted to, and then a handful of nurse practitioners and physician assistants. And then this is where they work. So ambulatory, inpatient, and long-term care are our three main buckets. And then we also pull from some community programs such as like Council on Aging, home care, other senior services agencies. So now switching on, I mentioned that we have had just a few providers go through the Respecting Choices training. And when we were first designing the program, we had a physician leadership team that really gave us a lot of input as far as, you know, what was needed to train the physicians. And two main things that came out of it was important for physicians to learn from other physicians, and that a full day training would have been a barrier, so limit it to a half day. The other thing was we were able to provide a stipend because we had the grant funds, so we were fortunately able to pay them for their time to come through this, and then offered CMEs as well. Now, I should say that the grant funds ended September 2016, so we no longer offer that stipend, and we're a fully funded program of Hospice of Cincinnati. So we worked with VitalTalk, and if you're not familiar with VitalTalk, they are a provider of communication coaching for providers, and really focus on communication skills. And that was another thing that the physician leadership team said was important. So just how to start initiating a conversation, become more comfortable. And the VitalTalk curriculum is set up, again, in small group sessions. So there's about 5 or 6 learners per facilitator. And for the role plays, we use simulated patient actors who are phenomenal. We are lucky enough to be close with the University of Cincinnati Simulation Center. And then actually one of my tasks within the first 6 months of coming on was to recruit new actors. So I looked at some community boards on where our actors find jobs and wrote up a job description, brought them in, kind of did a screening process of mini role plays. That was a fun experience, something I'd never done before, an audition. So we have usually 1 or 2 facilitators in the small group who really focus on putting the learner in the hot seat, and then practicing with the simulated patient actor, and then getting in-the-moment feedback from their peers. So similar to the Respecting Choices model. So who's our target audience? I said primarily, initially it was TriHealth primary care providers. We opened it up to some specialists. We've had some groups of the internal medicine and family medicine residents from TriHealth, which is an interesting group to be working with, some challenges of their own. And we've had some very interested medical students from University of Cincinnati reach out to us and say, hey, we want to come to this, and we invite them as well. So who are our VitalTalk faculty? So we do have one internally trained at TriHealth, but most of our faculty, so we have 11 total that we kind of contract with VitalTalk to bring them in, travel from Detroit, Cleveland, Pittsburgh, Indianapolis, and Columbus. So there's a lot of logistics that go into this training. It's coordinating the faculty, coordinating the actors, the learners. I kind of talk that it's more of like a performance, putting on a play. So VitalTalk is really known for their talking maps. So in Respecting Choices, we have the script that we follow. And then at Respecting Choices, it's kind of more big buckets of topics to hit. So Pause is really, we're focusing on the early conversation skills. And our patient actors, we have 2 scenarios. So pause, making the time. Just say, if it's okay with you, I'd like to add something to our agenda today. Ask permission and explain why. Understanding big picture values. So, the first scenario is a male in his early 70s. He had a sudden cardiac arrest at church, received bystander CPR. He's coming in for his follow-up visit, and the physician, says, what's important to you? And he says, being with my family. And then suggests choosing a surrogate. So in this conversation, if the learner asks some questions about, do you have someone to speak for you, or do you have those? He said, yeah, I have my wife, I have those documents. Then they start exploring a little bit more about, how has your wife gone through this experience? And you find out that she's not really stable as far as emotionally. It was really hard on her, and she probably wouldn't be the best person making decisions for him. And then explore a little bit more and find out that he has a son who is a medic in the Navy and is able maybe to be the better surrogate. And then probably what's the most important out of this is expect emotions and respond empathically. And this is sometimes a challenge. Some providers do this really well, others not as much, but our simulated patient actors are really the educational tool. So they are trained to ramp up their emotions, and if the provider responds with an empathetic statement or says, you look really frustrated or you look concerned or worried, they just kind of relax a little bit and open up a little bit more. But if that's not, they just start looping and just kind of talking in circles, and they're allowed to time themselves out of the facilitator, and times out, and facilitator, how is it working? He said, I don't know, he's really angry. And they said, well, did you mention that? Did you try naming it and see what happens? And they can try it again and kind of see how that relaxes them. And then remap. So this is later conversations and probably fits, so the early conversations probably fits most with the first steps curriculum, and then the late conversation skills probably aligns most with the advanced steps. So this is maybe later on in the disease process. For the other scenario, it's a woman with lung cancer and has Mets, and chemotherapy is no longer working. So coming into the conversation, reframe why status quo isn't working. The chemotherapy, we're at a different place. The chemotherapy isn't working. And then again, responding with emotion, expect emotion and respond empathically. What are you not telling me, or what do you not know? Why are you bringing this up? Mapping out what's important. So for the lady with lung cancer, you find out that she has a daughter with cerebral palsy and who doesn't live with her, and she's really worried about what's going to happen to her, when she dies, because her and her ex-husband, aren't really on speaking terms, but then you find out that he's come around through the disease process and she's, set with that. So aligning with patient values. So what's important to her? Staying at home, spending as much time with her daughter as she can, and then developing a plan to match those values. And this is a nice tool to bring up the hospice conversation. So, what's important to you? Staying at home. So we have this service, a team of staff who will come to your home, who can keep you comfortable, and that's called hospice. Because when you say those words, it's, no, I don't need that. But it's just a nice way to kind of reframe that conversation. So then nurses. This isn't one of the main talking maps, but we've kind of filtered it in along the way because this is really a toolbox for empathy and is nice not just in these conversations, but any difficult conversations. So naming the emotion, providing an understanding statement. I understand this can be very hard for you. Respectful statement, you've worked really, really hard. You've done everything we've told you to do. Support. We will be here along the way with you in this journey. Exploring a little bit more, and then silence. And that's, I think, something hard that we all as healthcare professionals have a hard time doing. We always want to provide more information, but just staying silent, allowing that space for the patient to share what's going on with them. So as I've been going through, you may have noticed some synergies between these two curriculums, and I just want to highlight a few, and then if anybody has additional ones, that I'd be welcome to hearing. But role play with in-the-moment feedback. Both curriculums do that. And every time when I say we are going to do role play and ask how many people enjoy role play, no hands go up. Nobody likes the role play. It's uncomfortable, it's awkward, but time after time on our evaluations, it is noted that that was the best portion of the training in both the Respecting Choices and the VitalTalk. Both are really patient-centered, focusing on what is important to the patient and aligning a treatment plan that matches those values, and remaining value neutral while doing that. And then some general interview skills, ask, tell, ask, exploring the meaning of words and phrases, and anticipate emotion and respond with empathy. And I will tell you, as being an instructor and a facilitator, I'm finding I'm using these skills in my everyday life with my kids, my husband, anything else? Yeah. Or what do you mean by you don't want to wear that outfit? So it can be used in many other ways. So going back to the primary care. So in the TriHealth primary care practices really served as the ideal learning lab to initiate this in our system. So at the time, back in 2014, we had 36 primary care practices. 100% of those were patient-centered medical home designation, and 19 were participating in the Comprehensive Primary Care Initiative, a CMS demonstration project, another way to kind of structure primary care. And one of the key roles in that was we had an RN care coordinator in the practice to manage the high-risk patients. And shared decision-making is a big component of CPC, and advanced care planning was our target for that. So it was really right for the system as far as that was a focus. So we had a total of 81 primary care office staff who were ACP facilitators. So mainly they were the RN care coordinators, both for CPC Plus and PCMH. And for the VitalTalk coaching, about 73% of the eligible providers participated. So for CPC, it was a requirement that they had to go through this. There was an incentive, we were able to pay them for their time. And it was being a measure, for CPC. So now I'm going to switch gears a little bit and talk about the electronic medical record enhancements that we did. So we developed a patient-level ACP summary report that was integrated in both ambulatory and inpatient models. It improved process for scanning the advanced directives into the medical record, and then we also developed a custom ACP best practice alert. And I'm going to go through each one a little bit more. So this is what our summary report looks like. It might be kind of hard to see from the back, but I'm going to point out a few sections. So first, the improved process for scanning documentation. So before, if somebody brought in their advanced directive, it would get scanned in and be lost in the media tab. But now, if we've improved the process so that if it's saved properly, it will pull over to the summary report and easily be found. We also created a discrete checkbox for initiating and documenting conversations. So we are able to pull and track how many conversations were happening. This was pretty loose as far as what we said was initiating. So anything from, do you have somebody to speak for you if you couldn't speak for yourself, to a full-on advanced steps facilitated conversation. Sure. Yeah, that's fine. That's fine.
For that box, does it pop up, or how do people know to go to the box to check?
Yeah, so there was some training. Oh, so yeah, repeat the question was, how does that box pop up, or how do people find it? So there was some training, and I'll get into that a little bit later as far as training people, because you do have to go and check the box. It's also tied to the alert as well. So. And then we developed an advanced care planning note that could also filter into the summary report. So if people had conversations, prior and documented. Now I will say it is a challenge to get people to use these notes. It's there, it's available. It's taking a lot of education because they want to document it in their progress note and not necessarily use this. So we definitely have some work on that. So I mentioned the best practice alert. So this is the criteria we used, and we used the Gunderson criteria. So 65 years of age and older, set of 12 diagnoses, cognitively intact, and we used that because we got a lot of pushback about creating another alert, one more thing. It's going to fire for every patient, so we started, okay, we'll just do cognitively intact. Not enrolled in hospice, 2 or more encounters with our health system in the past 6 months, and it will fire on the 3rd encounter, and then no end-of-life discussion initiated and documented, so the checkbox hadn't been checked yet. So this is what the alert looks like in the screen message. So an alert will pop up, says yes, now it's not a hard stop, so people can pass through it. It will continue to fire every 24 hours unless it's reconciled. So moving on to the technical support. So with the training, with the EPIC enhancements, it was quickly realized that we needed some support to actually implement this all and get it out system-wide. So first we developed a toolkit, Advanced Care Planning in the Primary Care Setting Toolkit. So it's a 48-page document, highlights, setting up a system to provide support for advanced care planning, how to prepare for a visit, how to have conversations, documentation, the EMR tip sheet, improving the process, and other supports and resources. So the process map for primary care, and I'll go through. So the model that Conversations of a Lifetime developed was that the physician would initiate the conversation and then hand off to the ACP facilitator to have a more robust and longer conversation. So making sure that the information was available to all patients. So we had posters that were available for exam rooms, waiting rooms. I'll show you a little bit later on in the Conversations of a Lifetime website. So we had website cards placed in, so that patients could visit it. And then, identifying eligible patients at the pre-visit planning. The physician initiates it, hands it off to the ACP coordinator, who then, has a conversation, does documents as appropriate, and then makes sure that they are scanned correctly into the medical record, and then continuing to follow up as needed. So we also realized that not just a toolkit, but an actual person was needed. So we created the role of the Advanced Care Planning Nurse Liaison, who's the third team member of Conversations of a Lifetime. I got permission for her picture. This is Colleen. She was previously a primary care coordinator, so she knew the primary care setting. She was very familiar with our EMR system and just really provided some great support and had good communication skills to talk to the care coordinators and say, hey, you can just incorporate this into what you're already doing. This isn't going to be just one more thing for you have to do. So she would go out to the practices, sit down with them, go in patient rooms, practice conversations with them, and she was our lead instructor for a while. She's since moved on to another role within TriHealth. But she would always tell at the trainings how, we say after the training you have to practice. And she would practice so much on our family members that they would say, are you really inviting us over for dinner, or are we practicing the conversation again? So she was just really kind of embraced this. So some results. So like I said, we had the checkbox to track how many conversations were initiated and documented. So we didn't have any baseline data, so we don't have any idea of how many conversations were going on before we implemented Conversations of a Lifetime. But you'll see the blue line is the CPC practices who had the full training, the support, and some of them implemented the best practice alert. And then the red line is the PCMH, where the training wasn't mandatory. Some kind of picked up on it. And you'll see that with so there was some focused ACP liaison support from January through June of 2015, and there was an uptick. And then you'll see a little bit of an uptick in the PCMH because they heard that we had this best practice alert, and they were really interested in getting on board with that. So there was a webinar, it was opened up to all practices. Some of them jumped on, you'll see the uptick, and then it kind of fell off again. And then this is the data broken down a little bit more. So I mentioned that Colleen, the ACP liaison role, it's been vacant since second quarter of 2017. So we really haven't had that ongoing practice support. So again, the blue line and the red line was from the graph before. And this green line, so in 2017, at that time we have 38 primary care practices. They all became CPC plus. And again, that's shared decision making. So you can see that even without ongoing technical support from the liaison, that conversations were sustained. It dropped off a little bit, but we also know that as more boxes are checked, the pool of eligible patients will go down as well. So take you through a success story. So a patient who's diagnosed with neck and throat cancer, and after chemotherapy, radiation, the cancer returned. Dr. Neal initiated the advanced care planning conversation with the patient and introduced him to the RN care coordinator and advanced care planning facilitator to facilitate a last steps conversation. And a quote from her is, "This patient was isolated from his family and society. He needed someone to talk to about his wishes. When we found out that it was a terminal situation, it was easy to mention that we had the resources in place." So over a series of visits, this patient met with the RN care coordinator, had several discussions, and completed a MOLST, a DNRCC, living will, and healthcare power of attorney, and made sure that it was scanned in his medical record. So in her quote, "It's been a really good experience for this patient. It's made him feel as comfortable as you possibly can, and he now feels less isolated." So some lessons learned through this process. We've learned that the ACP nurse liaison role is really crucial. Somebody who knew the EMR and who was familiar with the primary care practice setting. You know, again, people were comfortable picking up the phone and calling her, asking her questions. She made herself available. Also, a practice champion is successful for implementation and sustainability. Now, with the care coordinator role, something we didn't anticipate, that was a role that had a lot of staff turnover, so that each time somebody came on board, we had to retrain them, and there were some times where practices were doing really, really well. The RN care coordinator left, and then there was no activity. So the culture of each practice is a little bit different. And then the timing was right for the system with CPC going on as well. So some additional resources that we have, not only to practices, but anybody in the community, is that we have developed a mobile app. We worked with VitalTalk, who developed the custom curriculum for our physician coaching, to do a private label app. So using their content, there's a series of 15 different topics that you can click into. There's some sample phrases. It's quick. You know, if you're headed into a conversation, you can go in. I like the oops button. You know, oops, I said something incorrect. How do I back myself out of that? So it's a really kind of good in-the-moment coaching. Now I will say, so the grant was able to provide the funds to develop this, and we are no longer able to kind of support the updates, and I know VitalTalk has just kind of released an updated version. So this one will be going away in a little bit. And then the Conversation Starter Kit from the Conversation Project, we use that a lot for the practices. So not only the general one, but how to choose a healthcare proxy, how to talk to your doctor, lots of great toolkits. And then our website. So this is really consumer focused, and we have it pretty simple, laid out into 3 conversation bubbles. So I won't go into our community engagement, but we did some fun things for the community to get them more conversation ready. And that project was called Things You Shouldn't Wait to Say and Things You Shouldn't Wait to Do. We have some videos from that campaign, so check that out if you're able to. And then Start the Conversation is just how to bring it up. And then Resources for Taking Action is where we house all of the Ohio's documents, but where we're located in Cincinnati, we get a lot of patients from Kentucky and Indiana, so we have those, as well as a link to all 50 states' advanced directives, so it's easy to go and navigate. We also have an Info for Providers tab, where we highlight some books and articles for them as well. So this gives you a really good overview of the Conversations of a Lifetime program. So we've trained about 173 providers in the TriHealth practices, but overall we've trained 362 since 2013. And like I said, we have over 800 ACP facilitators. We've been able to document over 18,000 conversations initiated within our primary care practices alone. We have about 19 primary care practice sites who are regularly using the best practice alert. Now it's available and turned on for all. Some of them completely ignore it. They don't want to use it. It's just one more thing, but it's available. And then some of the numbers around the website visits and stuff. So this is our references just from that. And just want to thank you all again for your time and attention, and I'd be happy to answer any questions here. I also have my email up in case you want to reach out and talk a little bit more. So thank you.
Question over there.
Do you have any certain criteria that you need to have for it to count as a conversation? Like we have specifics for our facilitators that they have to touch on before we have them documented as a true facilitator?
Yeah. So we kept that pretty vague as far as what was considered. So, just asking, do you have somebody who could speak for you if you couldn't speak for yourself, all through, a full advanced steps facilitated conversation. So we kept that pretty vague just to encourage people to just initiate it. And I don't know if I answered your question earlier about the how to go to check the box. So there is, so if you don't have the alert and you use it, you do have to go out and check it. So it is, another step, but our nurse liaison was able to train people on how to locate it and find it and use it. So, Jim.
So there was a couple of things that you identified that seems to help with the sustainability of this implementation. The first is that nurse liaison, that seemed to make a big difference.
Yeah.
And then what you've built into Epic. What else would you say have been some key factors in helping sustain this effort?
I would say the CPC Plus initiative was huge because they are being measured on advanced care planning.
And the fact that leadership put it in
Yeah.
as a measurable outcome.
Mm-hmm. Yeah.
That's right.
Amongst the, it sounds like you trained 81 nurse coordinators as facilitators, and I presume that's all of the nurse coordinators.
Yes, and yeah.
So is that part of their job description now? And if so, if there's turnover, is there a plan to train the ones that get turned over?
That's a great question. Yeah, it is not part of their job description. And, when the nurse liaison, was in her role, she was very up on who's who in the practices. And if somebody was leaving and was someone coming on board, I've also built a relationship with the manager of all the care coordinators. So she is now just accustomed to, hey, I have a new staff person coming on board. We need to get them signed up. And we really suggest that they don't go through the training until they've been, in their position a couple months, just to kind of get them settled and figure out everything, because they have a lot of other things to do. So to not overwhelm them, and they come and say, how am I going to use this? So,
in speaking about not overwhelming them and sustainability, I heard you make a comment that you embed this work in the work that they're already doing, and they don't see it as something else to do. Can you tell the group a little bit about that?
about how they...
Would you repeat that?
Okay, so yeah, the question was, how did we kind of embed this into something that they are already doing and not making it something, an additional step? So that's where Colleen came in really well. She was really good at just kind of negotiating, say, hey, this person is coming in, they've just been in the hospital, they've been really sick, that's a really good time to just bring it up, how did that hospitalization make you feel? What are your fears? What are your worries? What if that happens again? So she was just really good at pulling that in. Oh, lots of questions.
Do you get any pushback from that? Like, we don't have time to have a conversation, because our conversations usually last at least a half hour.
Yeah.
They have to meet certain criteria. But do you get a lot of that, and how do you manage that?
We do, and it just kind of depends on the practice. Some care coordinators really embrace it. They think it's important. Maybe they've had a personal situation and they just think it is. And it's really trying to build a network among the care coordinators so they can learn and share. We've done kind of a refresher course where we've invited all the care coordinators back and just kind of sit around and say, what are you doing? What's working well? What's not working well? So.
And I just want to add to that, one strategy that we've seen be really successful in breaking up. So if they only have 5-10 minutes, do some of the exploratory questions, ask them to think about those goals and values, and then continue the conversation the next time they have contact. So.
We have one more question there, and then one up front here. So go ahead, finish.
Facilitators is rather impressive. What training do they need and require, and
I'm sorry, what was that, the first part of that? Oh, yes, yes.
That's rather impressive.
Yeah.
How are they trained? How do they maintain their training? And how is that funded?
Yep, so initially, well, we don't charge for the training. It's embedded into our operating budget. How do we maintain? So we have a email distribution list, so I will, send out updates and kind of, again, provide that ongoing support if they have questions. And occasionally we'll do kind of a refresher course. I mentioned the care coordinators. We've also done it for like long-term care. Anybody in long-term care, if you want to come, learn from each other. And that's yeah.
One more question back here.
So I have a question on marketing and consistency. So looking at the range of other types of models to incorporate, I'm really intrigued, but I'm also nervous about how to incorporate those and not confuse either those that are providing the conversations or consumers. And so how have you addressed some of that consistent messaging, marketing needs?
That's a good question.
Repeat it.
So the question was how, with bringing in lots of different resources, how to maintain that consistent messaging around the materials. So really kind of promoting Conversations of a Lifetime, the website, and then you can kind of go on and find additional tools that are from other organizations are housed there, and clearly, states where it's coming from.
Rebecca, did you still have a question?
Oh, well, I was just thinking in terms of the collaboration with Respecting Choices, some takeaway points for other people who are using Respecting Choices who might be thinking about VitalTalk. Like, what did you learn were some tips or tricks if people are going to do that collaboration?
Yeah, so we did kind of a sorry. So what are some tips and tricks if you're looking to collaborate between, we did VitalTalk and Respecting Choices. We developed a custom curriculum through VitalTalk, and we kind of said this is what we're looking for. Typically, I think it's a 2.5-day session, and said, we're really focusing on the Respecting Choices last steps. We want the facilitators to have the full conversation, and we want the provider just to be a little bit more comfortable initiating the conversation. So developing it through that.
Thank you. Are you going to be available afterwards?
I will.
People have other questions? Great.